Hello, my name is Melissa Daniels and I have strabismus. Strabismus is when your eyes are not pointing in the same direction and your brain isn't using them together very efficiently. I love learning about this, and I recently got to go to the optometry conference called OVDRA, and that's basically the big vision therapy conference that happens once a year. Over there, I was able to take some amazing classes and learn a ton, but my favorite class was called Redefining Success for those with strabismus. So I'm going to go into that and some things that I learned, my biggest takeaways, and share that with all of you because I think it is hugely impactful for the strabismus community. Before jumping into that, be sure you know you can go over to learn.strabismussolutions.com, or you can just scan this QR code. Over there, you're going to get a lot of different resources that can help you on your journey, whether it's the free quiz to kind of guide you on your path, or it is the Mastering Peripheral course that embodies some of the things that Dr. Cook teaches. There are a lot of different resources. You can also sign up for a Zoom call with me over there. If you prefer the audio version, you can actually go over to Healing Our Sight. That's a podcast by Denise Allen. She interviewed me all about this exact topic. And instead of putting that interview up here, I'm going to do a shorter version for my YouTube people. But if you want the long version, that link is going to be in the description. All right, let's begin. Dr. David Cook is a optometrist who practices vision therapy in Marietta, Georgia. He wrote the book that I love, Shape of the Sky, and his methods and his way of looking at this world and looking at strabismus when he has patients with strabismus completely changed my trajectory in vision therapy. The way he looks at space, my entire Mastering Peripheral course was inspired by him. It has changed my life and so many other lives of people who have taken that course. So David Cook is an optometrist who just gets strabismus and gets how to fix it in a way that a lot of others don't, or find strabismus intimidating. He's not afraid of it at all. He's like, it's fine. So recently he published this article, and I'm just going to show you. It is hefty. It's like 45 pages long. It's a research article, and he talks all about strabismus and what was measured historically, what was measured now for success, and kind of comparing them and talking about what is it that people with strabismus want to get out of vision therapy? What does a success look like? So first, I'm going to read you an explanation. There's a guy named Flom. I can't remember his first name. Merton Flom. Lovely name. He was an optometrist, almost 100 years ago, and he was really working, he studied strabismus and worked on binocular vision, and, he was really into this, and in his mind, a cure for strabismus was really specific. So I'm just going to read to you what he said, and I will put the link for this article if you want to read the whole thing. I'll put a link in the description as well. Bring a highlighter and a box of Kleenex. It's real good. Okay, so this is what he thinks is needed for good vision for someone with strabismus. Clear, comfortable, single binocular vision must be present at all distances up to the near point of convergence, which is normal itself. There must be stereopsis, which is kind of like 3D, where both eyes are, giving you information about where things are in space. So there must be stereopsis and normal ranges of motor fusion. An occasional turning of the eye may occur, only up to 1% of the time. And that's only if diplopia or double vision is experienced whenever this happens. So if your eye wanders and you suppress that second image, which is what happens for me, he would say that is not a cure. In order for it to be a cure, when you have that eye wander, you have to have double vision. And correction lenses and small amounts of prism, up to 5 diopters, may be worn if necessary. So I know you guys are not clinicians, neither am I, but that's like really hard, okay? Like if that was my definition of success in vision therapy, I would be the biggest failure, right? I do not have single binocular vision at all distances, definitely not. I have like up real close, I only use one eye. Sometimes in the distance, I only use one eye. Sometimes my eye turns. Gratefully, my eye suppresses that. So there's stuff that happens, and vision therapy still changed my life. And so Dr. Cook was starting to see this, like, well, I'm not getting a phlegm cure. They don't have this perfect binocular vision in all activities, in all distances, everything. But their eyes are a lot straighter, almost, not even perceptibly turned in any direction. And they are able to use their depth perception and their sense of space and where things are to have that peripheral fusion to help them get around in this world, to park, to drive, to play a sport, tennis, whatever it is. He's like, I'm giving my patients all that. My patients are thrilled. He's got success after success. These stories of people who he's changed their life, people with strabismus, but none of them got a phlegm cure. And so that's where that kind of was, this research was born, is him wanting to redefine what success means. Like, did phlegm have it all right? Or maybe we need to be looking at something different. I can see myself going on for like 4 hours with this video, so I'm going to really try to make it quick. So this is the article. Dr. Cook wrote this article. At the conference I went to, he gave a 2-hour lecture and kind of presented the information in this article, and then gave a lot of like clinical ideas on how to implement it, how to get those results. So if you get this article, you can look at all the cure rates. You can look at percentages. He separates it between esotropia, exotropia, less than 15 diopter turn, greater than 15 diopter turn. So he really separates it out and talks about what he did, what the success rates were. Dr. Cook redefines the success for a strabismus patient with a couple things. So he counts it as success if, one, the eye turn is less than 8 diopters. So if you look at my eyes right now, they're probably about like 5 diopters of esotropia. Especially if I look in the distance, it's a little bit more. But it's not really noticeable to the naked eye unless you're an optometrist. I'm sure an optometrist would notice my eyes, but if we met in the grocery store, you probably wouldn't. Okay, so less than 8 diopters. So that's basically like cosmetic. We have that cosmetic alignment. We're looking good, okay? The second thing on his list is improved stereo, or a minimum of being able to see the stereo fly. So there's a lot of different levels of stereo. It's not like an on-off switch, and the stereo fly is kind of the easiest one that they test for in like an ophthalmology office or an optometry office. You can also do like vectograms. Those are even easier than the stereo fly, but because he was doing their research and trying to make it like something that's more measurable, it was a minimum of being able to see the stereo fly. Basically, that is going to mean that you have some like big stereo, you can see the space, you can interact with the world. You've got, if you're looking at a vectogram, you can see the float on a vectogram. So that is his third measure of success, or second. And then the third kind of goes right along with it. They are able to have this egocentric awareness of space, know where they are, be able to sense something called silo. That's something in the vision therapy room, that it's a great measure, but that's just, it doesn't really matter as the patient what that is, but as the clinician, yeah, they want to see silo. That means small in, large out. It's just when you look at like a 3D something like this, and I spread these apart and I'm looking with my glasses on, it looks like it's floating. And as it comes in, it gets smaller, and as it goes out, it gets bigger. So that's what silo is. And so that's one of his rules, is they have to see silo. So less than 8 diopter eye turn, at least the stereo fly for basically like a stereo test, and then perception of silo and accurate spatial localization. I love this version of success because it's very patient focused. It's focused on what goals the patient has and what's going to impact their life and change their life, rather than what's easy to measure for a doctor. Right? It's easy for a doctor to measure those stereo tests, but that's not like really as impactful for how someone interacts in their world. Dr. Cook goes really deep into how he approaches both esotropia and exotropia. Maybe there'll be a future video where we go into all those details. That is not today's video. I will just say that his biggest focus is to start in the periphery, which you guys have all heard me preaching this. This is my whole Mastering Peripheral course, right? He says, aversion to fusion seems to be limited mainly to the macular and paramacular region. For this reason, fusion training should begin with the periphery and only gradually include the center. And the reason for that is because if you try to get fusion with your very central vision, your brain, what it's saying is you have an aversion to that. Your brain's like, no, absolutely not. And it's like moving the double image everywhere. It's like, we are not going to fuse. But if you start in the periphery, you don't have that aversion, and your brain is much more likely to accept it. Another quote from Dr. Cook: peripheral fusion alone seems to be just as effective as the combination of peripheral and central fusion in maintaining aligned eyes. So that idea that even if you don't have that small stereo, that peripheral fusion really helps lock in the ability to keep those eyes straight. And that straightens the eyes better and faster than all the central type exercises. I talk about this a lot on my video, but something where you're wearing red and green glasses and you're playing Tetris. This is always like the perfect example. And half the block can be seen with one eye, when you're wearing these glasses, and half the block can be seen with the other eye, and you have to like have them perfectly lined up, and that is super central, and that just kind of wreaks havoc on a strabismus brain. And Dr. Cook doesn't even touch that stuff. He's like, no, I don't even worry about that. Like, we just work on that peripheral stereo, and that is what gives them alignment. That is what gives them all of those things that he's looking for. I also love that he addressed anomalous retinal correspondence, or anomalous correspondence. It seems like it's called a lot of different things. It is a confusing concept, but as patients, all we need to know is when we were babies, our eyes weren't straight, our retinas didn't talk to each other correctly. So it's like one eye's using the center of the retina and the other eye is using like a different part. So even if the eyes are aligned, things just aren't, like the central vision just never is quite right. Can it be fixed? Yes. So hard. And really, again, isn't as impactful as other things that you can do. This is what Dr. Hook has to report about ARC. Thus, our approach of ignoring and working around ARC does not seem to harm functional cure rates and may well have overall led to straighter eyes and improved stereopsis in a greater percent of patients. So he's kind of talking about what he is getting versus surgical results in a lot of these studies. And basically, he's like, we just don't worry about ARC. When we have that anomalous correspondence, like, okay, that's fine. We're not doing central activities anyway. We're working the periphery, and that is not affected by ARC at all. That ability to get peripheral fusion, not affected by ARC. If you stay out here, it's going to be fine. You're not going to get irretractable diplopia. I highly recommend going back and reading this article and learning for yourself. It was so helpful to me. I just felt like I'm not a failure. Just because I don't have randot stereopsis doesn't mean that vision therapy didn't change my life. And sometimes I need that reminder. Sometimes I feel like maybe it didn't do anything. Maybe I'm not any better off than I was when I first started, right? Like you start second guessing yourself. And to hear this just helped me realize, like, no, this did change my life. This is real. This is so much different and so much better than it was before. And my eyes are staying straighter. Like all of it is so great. And so I just felt like justified. And, I get people saying like, well, if you don't have randot stereopsis, then it doesn't really count. And I'm like, I don't care. I don't care about a Flom cure. I care about a Cook cure. That's what I want. I want to have the way it looks and the way it functions. Doing good, that's all I care about. If you want to learn more about how to use your periphery, you should definitely take my Mastering Peripheral course. It will help you learn how to do it, right? Like it's easy to say it in practice, like use your periphery and learn peripheral fusion, but the course really gives like a how-to and breaks it down to help you on that way. I've had so many people who are in vision therapy say that this was like the secret sauce that really helped them start to take off in their vision therapy because they finally understood peripheral and space and all of those things. It is a huge piece, and hopefully this video helped you understand why.